Two people, same Sjogren's diagnosis, same positive antibodies on the same blood test. One is still working full-time, raising children, living a full life. The other cannot get through a Tuesday without spending the afternoon in bed. Same disease. Two completely different lives. Why? Most people will point you to SSA antibodies, exocrine glands, lymphocytic infiltration. I'm going to show you something you can actually picture. A system. And by the end of this video, you will be able to explain Sjogren's in a way that finally makes sense, to yourself, to your family, and to the people who keep telling you that you just look tired. If that sentence just landed for you, if something in what I've described so far sounds familiar, I've put together a symptom map that shows exactly how this condition progresses, what shows up at each stage, and where the standard tests are most likely to miss it. Type symptom map in the comments right now and I'll send it to you directly. Because what I'm about to show you next is why that map matters more than most people realize, and why the stage you're in changes everything about what happens next. Most people think Sjogren's is a dry eye disease. And that is the single most dangerous misconception about this condition. Because people who believe Sjogren's is a dry eye disease spend years using eye drops and wondering why they still feel like they are falling apart. Sjogren's is not a dry eye disease. Sjogren's is a supply chain disease. Your body runs on a network of glands and fluid systems that keep every organ functioning. When that supply chain is working, you never think about it. When it starts to fail, nothing in your body works the way it should. And here is the critical point. By the time you feel the dryness, the supply chain has often been failing for years. So let me show you what I mean. Your body is a factory. A factory with 5 departments that all depend on each other to stay running. The first department is the fluid production unit. This is your exocrine gland system. Tear glands above each eye producing the 3-layer tear film that protects your cornea. Salivary glands producing up to 1 liter of saliva every single day, not just for taste, but for digestion, for tooth protection, for the antimicrobial shield that lives in your mouth. Mucus glands in your nose, throat, lungs, vagina, gut. Every surface in your body that faces the outside world is lined with fluid that this department produces. If the fluid production unit shuts down, every surface it was protecting starts to break down. The second department is the security system. Your immune system. In a healthy factory, the security system knows the difference between foreign threats and the factory's own workers. It destroys viruses, bacteria, and abnormal cells, and it leaves the factory's own departments alone. But in Sjogren's, the security system gets a faulty signal. A miscommunication between genetic vulnerability and an environmental trigger, often a viral infection, sometimes hormonal shifts. The exact trigger varies and researchers are still mapping it. What we know is this. The security system starts treating the fluid production unit as if it were the enemy. It sends lymphocytes, immune cells, to infiltrate the glands. They surround the glandular tissue. They crowd it out. They destroy it. And destroyed gland tissue, unlike muscle or skin, does not regenerate. Once it is gone, it is gone. The third department is the wiring room. Your autonomic nervous system. This is the department nobody talks about in Sjogren's, and it is the one that explains why so many patients feel far sicker than their dry eyes and dry mouth should warrant. The autonomic nervous system controls the functions your body runs without your conscious direction. Your heart rate. Your blood pressure when you stand up. Your digestion. Your temperature regulation. Your sweating. Your breathing rhythm while you sleep. In Sjogren's, the same immune attack that targets the glands also targets the nerves. Autonomic neuropathy occurs in nearly half of all people with Sjogren's. Nearly half. And this is the department responsible for that feeling of standing up too fast and nearly blacking out. The racing heart sitting still at your desk. The digestion that has slowed to almost nothing. The body temperature you cannot regulate. When the wiring room is under attack, you do not just feel dry. You feel like your whole operating system is glitching. If the wiring room resonates with you, type the word wiring in the comments right now. You need to know you are not imagining this, and other people watching this video need to know that they are not alone in it either. The fourth department is the energy room. Researchers are finding increasing evidence that mitochondrial dysfunction plays a role in the profound fatigue of Sjogren's. Your mitochondria are the power generators inside every cell. When they are running correctly, they convert the food you eat into usable energy efficiently. When chronic inflammation and immune activation are running in the background day after day, those generators get worn down. They work harder and produce less. This is why the fatigue of Sjogren's is not the fatigue of a bad night's sleep. It is the fatigue of a generator that has been running on emergency power for months. Rest does not fix a depleted generator. It just stops it getting worse. And that is why patients often describe waking up after 10 hours of sleep and still feeling like they have not slept at all. The fifth department is quality control. Your bone marrow, your lymph nodes, the B-cell production lines that the security system relies on. In Sjogren's, the ongoing immune dysregulation causes some of these B-cell production lines to overproduce. They become hyperactive. They start making more antibodies than the body needs, including antibodies against things that are not threats. Over time, in approximately 5% of people with Sjogren's, this B-cell overproduction crosses a line. It becomes non-Hodgkin's lymphoma. That number, 5%, sounds small. But it represents a lymphoma risk that is between 5 and 44 times higher than in the general population depending on which risk factors are present. Cryoglobulins in the blood, a persistently low complement C4, palpable purpura on the skin, parotid gland swelling that keeps recurring. These are the warning signals and quality control that every rheumatologist should be watching for at every visit. If your rheumatologist checks your cryoglobulins at your annual review, type the word checked in the comments. If they do not, this video may change what questions you ask at your next appointment. Now here is where the factory metaphor becomes the single most important thing you can understand about why two people with the same Sjogren's diagnosis can have such different lives. The security system does not attack every department equally or at the same rate in every person. In some people, the attack stays concentrated in the fluid production unit for many years. The glands are damaged, the dryness is real, but the wiring room and the quality control department remain largely intact. These people manage. They function. They use eye drops and saliva substitutes and they adjust. In other people, the security system spreads. It reaches the peripheral nerves, causing burning feet, numbness in the hands, pain that travels and shifts and has no obvious cause. It reaches the kidneys, where a specific pattern called tubulointerstitial nephritis develops in the majority of Sjogren's patients who develop any kidney involvement at all, often without the patient ever knowing because there is no pain. It reaches the lungs, causing interstitial lung disease that shows up on a CT scan before the person has any breathlessness. It reaches the spinal cord, and in those cases the symptoms can look so much like multiple sclerosis that the person gets diagnosed with MS first. In some medical centers, this misdiagnosis persists for years, because certain MS treatments can actually trigger a Sjogren's flare, making the patient visibly worse with no obvious reason why. And here is the fact that should change how this disease is discussed in every clinic in the world. The average person with Sjogren struggles with symptoms for between 6 and 10 years before getting an accurate diagnosis. 6 to 10 years. In that window, gland tissue is being destroyed. Nerves are being damaged. Kidney tubules are being silently infiltrated. The lymph nodes are under sustained immune pressure. Every year of diagnostic delay is a year of unchecked damage in a disease where the damage is largely irreversible. Sjogren's is not rare. Estimates suggest it affects around 1% of the global population, with some analyses placing the number higher when secondary Sjogren's is included. 9 out of 10 diagnosed patients are women. The peak age of onset is between 40 and 60. But it can and does occur in children, in men, and in people in their 20s whose symptoms are dismissed for years because they are too young to have an autoimmune disease. If you were told at some point that you were too young or too healthy looking for Sjogren's, type the word young in the comments. Because this happens constantly, and the people it happens to deserve to know they are not alone. Now let me tell you 3 things that the research supports and that most patients are never clearly told. The first is about your teeth. Saliva is not just for taste. Saliva is your mouth's immune system. It contains antimicrobial proteins, enzymes that begin digesting food, bicarbonate that neutralizes acid, and calcium phosphate that remineralizes your enamel after every meal. When Sjogren's destroys the salivary glands, the mouth loses all of that protection simultaneously. Dental decay in Sjogren's is not poor oral hygiene. It is the destruction of the biological shield that was keeping the teeth intact. Cavities that appear at the gum line, that spread rapidly, that recur despite careful brushing, these are a clinical sign of salivary gland failure. A dentist who does not know this will treat each cavity and never connect them. A dentist who does know this will immediately refer for Sjogren's assessment and will apply fluoride varnish at every visit, recommend prescription-strength fluoride toothpaste, and help monitor the rate of deterioration. If you have Sjogren's and your dentist does not know your diagnosis, that conversation needs to happen this week. The second is about the eyes. Dry eye in Sjogren's is not the same as ordinary dry eye. The tear film has 3 layers. An outer lipid layer that prevents evaporation. A middle watery aqueous layer produced by the lacrimal glands. An inner mucin layer produced by goblet cells on the surface of the eye itself. Sjogren's attacks the lacrimal glands that produce the aqueous layer. When that middle layer fails, the tear film becomes unstable, it breaks apart within seconds of a blink, and the corneal surface starts to dry between blinks. Over time, without adequate treatment, the corneal epithelium develops erosions. The surface of the eye starts to scar. Vision starts to deteriorate not because the eye itself is failing, but because the protective film that covers it has been destroyed. This is why standard over-the-counter eye drops designed for ordinary dry eye often provide only partial relief. Sjogren's dry eye needs preservative-free drops, used frequently, alongside treatments that address the underlying lipid layer and mucin layer dysfunction. Punctal plugs, which block the drainage channels in the eye and keep what tears are produced on the surface longer, can make a significant difference when drops alone are not enough. The third is about your immune system and what is still possible. There is currently no cure for Sjogren's. But the immune attack is not entirely outside your influence. Hydroxychloroquine, an antimalarial drug that has been used in autoimmune disease for decades, dampens the type of immune signaling that drives the damage in Sjogren's. Studies show it reduces fatigue, reduces glandular inflammation, and in some patients slows disease progression. The earlier it is started, the more gland tissue there is left to protect. For patients with systemic involvement, stronger immunosuppression is available, including drugs that specifically target B-cell activity, which is the primary driver of glandular destruction and lymphoma risk. The research pipeline for Sjogren's is more active now than at any previous point in the history of this disease. Clinical trials are currently evaluating biologics that target specific cytokines, monoclonal antibodies that interrupt the immune signaling cascade before it reaches the glands, and therapies that aim to regenerate salivary function in glands that are damaged but not yet fully destroyed. If you want to know whether any of these trials are currently recruiting and whether you might be eligible, type the word trials in the comments, because that is a video we can make, and the more of you who ask for it, the sooner it gets made. Now let me be clear about something. If you or someone you love has a Sjogren's diagnosis, this video is not a replacement for your rheumatologist's plan. The medications, the monitoring, the specialist reviews, those decisions belong to the people who have examined you and reviewed your blood work. What this video is a map. Because when you understand what the factory is, what each department does, and which ones are under attack, you stop feeling like you are describing random symptoms to a doctor who cannot connect them. You start walking in with a language for what is happening to you. And that changes every appointment you will ever have. The earliest signs of Sjogren's often have nothing to do with dry eyes or dry mouth. If you want to know what to look for before the obvious symptoms appear, the signs that show up years before a diagnosis, have a look at this video right here. I hope that gave you a clearer picture. Maybe I will see you over there. Thank you for watching. Bye bye.